we all get disorganized after food. And it has happened today too. Let's see after lunch. Okay, so we have our next abstract presentation by Gladys Biwott. Her presentation is on pain and fever management among people living with sickle cell disease. So let's all welcome Gladys Biwott onto the stage with a round of applause. Please, continue.
Good morning, everyone. You're fine. So I'm still waiting for my slides. Yes, I'm Gladys Biwott. I'm a clinician from Kenya. I've done public health, BSc, Masters in Epidemiology and Disease Control. I'm currently pursuing my PhD on epidemiology again. And today I'm going to present on pain management among people living with sickle cell disease. This is one of the non-communicable diseases, which is autosomal recessive disorder, most commonly along the shores of Victoria and the coastal region of Kenya. It is one of the diseases that is neglected. It is not being mentioned as one of the NCDs. As much as we are trying as a country, we are still having more than 14,000 births of children or adults with sickle cell disease. So, as in a facility, I formed a support group for sickle cell. I started it in 2016 with around 20 children and 5 adults. Currently, I have more than 100 children who have those living with sickle cell disease. So I wanted to see how best can we manage their pain. They usually have painful crises, sequestration crisis, anemic crisis. So they're always, the main thing that brings them to the facility is pain. Thank you. So I had to do a case management treatment of generalized body pains for those people living with sickle cell. A sickler or any patient who has sickle cell, they have a biconcave shape of the red blood cell. But for a normal person, it is not biconcave. So for a sickler, they usually have a biconcave red blood cell, which carries less oxygen throughout the body compared to a normal person. As you all know, it is an inherited disorder. You can give birth to a sickler if your partner is a carrier and you're also a carrier. Then you can have 25% children who are having sickle cell. You can have 25% who are carriers and 50% healthy children. So it is a multi-system disease. It affects from head to toe. All the systems are affected. the CNS, you can have stroke, you can have severe chest syndrome, you can have mesenteric pain, and also the joint pains because of occlusion. So usually, the RBCs of people who are living with sickle cell have HBS, which is it is the abnormal form, which is usually carrying oxygen around the body. For them, they have beta globin alanine includes the sickle cell mutation, and second B globin alanine includes another gene mutation. There is mutation in their B globin alanine, the DNA. There is replacement with thiamine. So for a person to be referred as having sickle cell anemia, they have to have over 90% of the hemoglobin S. So when you do HB electrophoresis, you're able to identify that a patient has sickle cell disease. So the pain that these children undergo, or adults, they usually have painful crisis. That is one of the signs. They can have all types of pain. There are acute pain, chronic, intermittent. There is always a pain management strategy that are supposed to be applied to any other person. But for sicklers, they need to be using these other painkillers like codeine and non-inflammatory NSAIDs. They're supposed to use NSAIDs because the moment you have occlusion, you're likely to have inflammation in the occluded part anywhere. It can occlude in the bone, it can occlude in the brain, it can occlude in any part. They're usually in severe pain. So the Sickle Cell Federation of Kenya have really tried that they're supposed to be using their essential drugs that they're supposed to be using. There is hydroxyurea, PenV, folic acid, and paludrine. For paludrine, because it is common in malaria endemic zones, they're supposed to be using it every day. But remember, they're coming from poor background. So those who can afford, paludrine goes per tablet, it's around 50 shillings per day. And you're supposed to take like 4 different types of medication. So they end up having crisis each and every moment. That's why they usually come to the facility. So the issues of optimal treatment for both individuals and also for the whole interdisciplinary care for the whole patient. We need everyone on board. It is not about healthcare workers alone. We also need the community. We need our leaders to also help us to make policies so that we can see how we can help these patients. So we need early diagnosis to help us make awareness. Like what I am doing at the facility on behalf of clinical officers, I started a support group so that we can also tell them the signs and symptoms, the nutritional part, how can they move around this thing? If I am a sickler, I can see how I can get married to anyone who doesn't have the genes so that we don't give birth to children who have sickle cell. So there are new guidelines which are put in place so that it can emphasize on early diagnosis and also to reduce the mortalities due to the complications caused by the condition. So I collected data. It is a case study. So patients who came through outpatient clinic, because I'm a clinical officer based in outpatient department, so we have a system that is currently being used in Kenya called Elephant System. So I'm able to trace how many sicklers came to the facility, how many had painful crisis, which drugs were they given, did the drugs reduce the pain, were they given the right one as per the guidelines. So I used an observational checklist. I interviewed the the participants. Then I subjected the participants into taking the ibucap. Ibucap is a painkiller. It is an NSAID. So from this particular study, those who were able to consent were allowed to participate. Not everyone was forced to participate in the study. So approximately 90% of the patients having pain, majority of them could afford folic acid because our leaders are here. In our facilities, we only have folic acid. Hydroxyurea, paludrin, strong painkillers are not there. So as clinical officers, we were able to only prescribe what is there, not what the patients are required to have. Sometimes you are forced to mix brufen and paracetamol. You can give the two of them so that it can help you in inflammation at the same time in pain. Then the clinicians could tell us that they were given paracetamol suppositories for the ones who were young. But remember, inflammation is going on. So the part of inflammation, it is not sorted. These patients will still come back. So for adults, they're given the same drugs. But sometimes you can get tramadol. For clinicians, I know we can have tramadol in our drawers. So we inject them, they give us money. Sometimes we prescribe, they buy, they're injected. But those who could afford ibucap showed reduced number of hospital visits from 4 times in a month to once in a month. But those who preferred paracetamol or herbs, they came to the facility more frequently, which was not a good sign for us as a facility. So, but we still have barriers as a country. We don't have specific registry to know how many sicklers do we have as a country. How many are on which drugs? How many are on the right treatment? Then we have ignorance among healthcare workers to adhere to the guidelines. If I ask any of us, do we have a sickle cell guideline in our area or at our workplace? We may not be having them. So for the moderate to severe pain, we are supposed to treat with opioids. But we usually fear giving out the opioids. At the same time, the opioids are out of stock. So good drugs like morphine and the rest, they're usually given in the wards. But in the outpatient department, where most of us work, these drugs are not prescribed, they are unavailable. So from this study, I would suggest there is need for improvement on sickle cell pain management. Then the health experts in Kenya, we can help reduce the number of children born of sickle cell if we do early diagnosis. There is isocentric lab tests. They're usually done to neonates. So we can start us from that place so that we can also educate our people and make more awareness as from the villages, from your neighbors, so that we reduce the number of children born with sickle cell diseases. So as a country or as healthcare workers, we should have a broad spectrum or broad pain management approach, which will always include all stakeholders. It is not about, it is not one-man show, it's all of us. So then it's a good practice to provide patient-centered education and surveillance related to NSAIDs toxicity, so that we also don't give just to reduce the pain and forget about the side effects. So I'll always recommend that all of us, or the study recommend that we give drugs such as ibucaps, that's so that it can help us sort the inflammation and the pain. We should form more support groups so that we reduce the current number of children, 6,000 newborns, to around 500. So that is like reducing. Initially it is 1 in every 150 newborns. So it's better we reduce to 1 in every 100 by 2050. IT, kindly help me. This thing is not working. So I acknowledge the medical superintendent, Kombewa County Hospital, Dr. Vincent, clinical officer in charge, and the hospital staff, and all those who participated in the study. So this is one of the support group meetings that I usually have. It's still the same. Thank you so much. Thank you for your time.
Starts with Mheshimiwa Dr. Pukose.
Thank you, and thank you, Gladys, for the good presentation. Mine is just a comment. Kombewa apparently is in same constituency and is represented by Honorable Dr. James Nyekal, who happens to be a member of my committee. I'm aware there is a Kemri pediatric ward in Kombewa, which my committee has put in some money to support it. Issues about sickle cell anemia and sickle cell disease. There is a study being done by Dr. Mulure and the team. And apparently, we also have some support from the Kenya Tissue Transplant Authority, in which I think among the management, we are considering introduction of apheresis, because we think exchange blood transfusion can be able to improve the quality of the patients or of the sicklers. So I think one of the takeaway things would be that if in those areas that we have incidents of sickle cell disease, if we can introduce screening at both, even in the neonatal period, so that screening can be done as a routine investigation, I think it could be able to help, so that maybe as you do your study, you can now improve into even ask those mothers who come with the children, whether they went to antenatal clinic and whether the screening for sickle cell disease was done. And then maybe go further and link up with the Kenya Tissue Transplant and the team of Dr. Mulure to see if apheresis, as we build the pediatric ward in Kombewa, if apheresis can be introduced as part of the treatment within that area. I think that can be able to improve the quality of life of the patients or of the sickle cell disease. That's just my comment.
Thank you so much for the input. Currently, there are studies which are being done by Walter Reed Project by Dr. Janet, Dr. Walter. So there's so much that is being done, but most of the participants, they got from the support group. So in Kombewa, we are passionate about sickle cell. We will welcome anything that will improve the life of a sickler. Thank you.
Okay, thank you. Let me introduce myself again. My name is George Gibore. I think what you presented is quite interesting. As the doctor has said, indeed, I think it was last year, the government now have a policy on sickle cell, which actually provide for framework of primary care interventions, including early screening for all children who are born in Kenya, and probably maybe with a priority to start from the region which are mostly affected. So that could have been actually been one of the focus, because then we are looking at what are our recommendation in terms of a better management to ensure that we are avoiding crisis, as you have mentioned clearly. So mine was that. So to do that, I think then once there is such a policy, probably when there is a high caliber representation of our representative here, maybe the recommendation will be now a mandatory provision of the government, so that then those regions that are highly affected, they can allocate resources to ensure that now all children born within that age can be able to get maybe a screening to ensure that we have an earlier diagnosis. Thank you.
Thank you. I think I mentioned on early screening. Thank you, Mr. Gibore, for adding that. Another question? Addition?
Okay, thank you. We have a lady here.
Good afternoon.
Good afternoon.
My name is Lucy from Kenya. I work in a region that we know that sickle cell actually goes in, it's in a Kenyan distribution, is in a few pockets, that is along the coast of which I work. And I think in Nyanza, where the prevalence is also high. So this question, I realized that when we talk about sorting a problem that has already happened, the screening and the early treatment and management of the children. I would ask this on behalf of Kenyans and probably also for the other nations, but on my country, and you are from there, I don't know why the government has shied away or why we've not done much. I hope the legislator within are hearing. The role of a clinic officer is preventive, like we were taught yesterday and reminded, curative, rehabilitative, and promotive. Now, I don't know if we are failing our patients, because just the other day I had a young couple and their firstborn had turned positive for sickle cell, very severe crisis. They came in my office. Then they recently had a child, and 3 months down the line, the child again has tested positive for sickle cell and also came in severe crisis. Now, this young man, I think 29 years old, was very devastated. And he said he blames first his grandfathers, then he blames his father, then he blames me as his clinician, and then he blames the government because all this time, nobody had actually informed him. But that is an engineering student now we are talking about, not someone in the village. An engineering student, an engineer, that is, somebody you would assume was aware of such a situation, such a disease. He says if he knew, he's not stupid, sorry to use the word. He would have taken precautions. He would have had his girlfriend tested, and he would have made a difficult but necessary decision at that moment. So I don't know why our government or other governments, we have shied away from aggressive, promotive, and preventive measures towards that, so that even if probably there is a requirement in marriage, like we had at one time on HIV, and we were able to bring down the prevalence. So we really need to get from the beginning. We really need to come up with ways of seriously educating our people, allowing them to get screened prior to marriage, and then they make that decision when they get there. Yes, we are going along, then maybe we'll not have children. Okay, we are African, but we allow them to make an informed decision before they get into a union, where sometimes is actually very, very painful. Thank you very much.
Thank you for the input. I think if Dr. Kose comes to Kombewa today, when you want anything concerning sickle cell support, talking to clients, you will be, I'll be the first person he will meet. Have tried as much as I can so that I do sensitization. I understand what the couple is undergoing. You can imagine what I do to the ones in the rural. They don't understand. You get someone who has more than 4 children. All of them have sickle cell. It is so painful for all of us as clinical officers. We are the champions to educate our people. Next question.
Oh, thank you, thank you. Actually, this presentation is arousing emotions, and I won't stop there. I will have to take as many questions possible, but we are now going to put a caveat. Your question should be, or comment should be at most a minute, so that we can have a very good number of people presenting. Thank you. Welcome, Dr.
Thank you very much. My name is David Jeru from Kenya. Thank you, Gladys, for your good presentation on sickle cell pain management. Indeed, we know sickle cell crisis is very, very painful. I've only 2 concerns. One is how you classified pain. What criteria did you use to classify pain as mild, moderate, and severe in order to decide which patients to put on analgesics? And secondly, you have recommended Ibucap, which is an NSAID, and we know long-term use of Ibucap has hepatic and renal complications. Did you consider that?
Thank you. For the pain classification, we have a guideline. It is usually put in the outpatient department. So you are able to see which one is for intermittent, acute pain, and for chronic pain. But for Ibucap, we did EUCs for all our patients and LFTs before starting anyone to, you remember I have more than 120, but I chose 30. There was inclusion and exclusion criteria for all my participants. So anyone with chronic illness or chronic complications were not allowed to participate in the study. Thank you.
Thank you. Another question, please.
Thank you so much. Blessings, Chigasema from Malawi. And I would like to thank you for your presentation. Quite provoking and interesting. Your protocols, probably more, it was more focused on medical management of pain. Now, I would like to know, probably we also have psychological interventions for pain as well, especially in palliative care. I don't know, looking at the population that you were dealing with, was there any psychological intervention of pain that could maybe have effects on your results? Yeah,
Thank you, Blessings.
Yeah.
For I said it is multidisciplinary approach. So because today I was just dealing with the physical pain, but when they come to the facility, or anyone, those who participated in the study and those who did not participate in the study, you have to do all approaches: emotional support, psychosocial support, their nutrition well-being, their adherence to medication. You cannot do one way. You have to do it multidisciplinary. Thank you, blessings.
Okay, thank you. I think we've had a good share of male representation. I think we take the ladies more now. But quite a number of you people will be given a chance. A minute for everybody.
Good morning. We're almost in the afternoon. Good afternoon, everyone. My name is Frida from Kenya, and I'm a sickle cell champion. And I want to appreciate the work that you've done in that research. Truth be told, I think in as much as a colleague Lucy said, we are more into the medical management other than the preventive management, promotive management of these patients. Now, I just want to echo out that during the first international sickle cell conference and hemophilia that happened in Nyanza about 2 months ago, there was a declaration that the government should come in handy to actually see into it in the chronic diseases, sickle cell being in the limelight. The data with sickle cell currently, and someone echoed out that we do not have NCD registries. So even right now, if you go to ministry, you will not have a database for this, okay? It has been a market hole for the treatment of the sickle cell patients for people's benefits. Yes, I want to echo out. Government right now should give priority to actual sickle cell prevention, promotion of promotive education to these patients. Now, even with treatment of in pain management, the basic major thing is to actually make the blood thin. That is the only way you can actually reduce the pain in this patient. But my echoing out to all of us is that when we're talking about pain, it is not just by looks. So even with the WHO standard of pain management, it should be patient-based. Now, our dear presenter, the chronicity of the disease, funny enough for the sickle cell patient, has shown they're best for the study than actually being in the exclusion criteria, because they're the ones who suffer more crisis. So it is good to actually include them in the study, and it will give you a better outcome even as you talk about pain management. Then again, because the one who is in chronic state, then they will have more problems than compared to those who we leave out and we think are the best class. For the sicklers, I would go for more of the chronic cases. Thank you.
Thank you so much for the input.
If you wanted to clap, just clap kindly.
Good afternoon.
Good afternoon.
My name is Harriet Maneno from Kenya, Kilifi County, and I run the pediatric, I specialize in pediatrics, so I run the pediatric outpatient and emergency department. So it's just an importer to mostly directed to our chair health committee. So apparently the sickle cell drugs, which are hydroxyurea to be specific, it reduces the pain crises in a year for almost 50%. But then when diabetics, hypertension came to NCDs, we forgot about sickle cell. So at the NHIF, they can pay for insulin. The NHIF includes the drugs for diabetes, the drugs for hypertension, but apparently doesn't cover hydroxyurea. And hydroxyurea is very expensive. I think it's 50 bob per tablet. The current chief, but the previous didn't have. Okay.
Yeah, thank you. I think this presentation is giving us an insight that clinical officers, we have a very big role to play in in controlling the chronic diseases. Another question?
Once again, my name is Doreen. I just want to request our government officials that are coming from Kenya here that the most important thing is to avail the medicines to these people. Because once you avail the hydroxyurea, then you're going to see less of these people living with sickle cell coming to your clinics. Because they will live life pain-free, but because they cannot afford, they keep coming to you for the painkillers, or they keep coming in the crises that they have. For instance, in Uganda, we have people that have sickle cell. There are quite many. We are running these clinics at regional referrals and district hospitals. But the numbers we see are very few because our governments avail these medicines for free. So if this can be adopted in Kenya, in that people with chronic illnesses can achieve this at maybe a small cost. Let's say if they're contributing, I'm used to the Ugandan currency. If they're contributing maybe 1,000 shillings, probably a month, and then the facility is in position to avail the hydroxyurea for free, then you would reduce on the patient load that you have. Thank you.
Thank you, Doreen.
Thank you very much. A clap for that, kindly. This session is more of what the presentation is more of a policy changing presentation. And I think I will also I'll give an opportunity to the leadership here also to make a comment.
Good morning. A very insightful presentation, of course. My question is that after noticing one recommendation that you had made to say Ibucap was better than any other NSAID, I just wanted to know what was the duration in terms of how you had given your Ibucap, knowing the ethical consideration of the side effects of the drugs, to say one of them, it can be like, it can bring about ulcers or stress ulcers. Then two, I want also to know whether there was a consideration of the pharmaceutical company that we had used in terms of specification of the Ibucap to use. Knowingly to say, Ibucap, of course, is a trade name when it comes in various compositions. Thank you.
Thank you. You can ask then.
Yes, mine is just a comment. If you look at the statistics available and the prevalence of the sickle cell condition itself, every day people are being born with sickle cells. What will be like the cost-benefit analysis of having a policy, which will be like a difficult decision, but it's a policy that will work. Some countries have tried, especially in the Western world, where we try to see how policies can be channeled in order to have this difficult decision of not getting involved with a person, especially when you are SS, both SS, to have a policy that we don't allow these people to get married, especially now that majority of the marriages are coming through court wedding. I think these are things we can push for as healthcare workers once we have the data, that it is better we have this comparatively to pushing for a policy where there will be upscale of the availability of the available drugs over a period of time. The cost-benefit analysis, in my personal view, will be it will be more cheaper for government to have policies that prevent the occurrence of marriages that occurs between SS than upscaling the availability of medicines over a long period of time.
Thank you. I think for policies, we are humbled to have our Chair Committee of Health from Kenya, Honorable Pukose. I think for policies that have been implemented, it is one of the NCDs that is being discussed even at parliament level. So for the pharmaceutical company, it is called Shalina. They gave me an authorization. We went for review. We have an institutional review board in our country that always gives us a go-ahead to participate in any study. So for the exclusion and inclusion criteria, we did baseline lab tests so that we can see who is going to benefit from EBUCAP and those who will be excluded. For those who have peptic ulcer disease, the pharmaceutical company were able to do endoscopy for some of the participants, but it was very expensive. Yeah, so some people had to know to participate. Thank you.
Okay, we have another question from Kenya here. Come.
I always do not have questions, but just to add or a clarification. I am an anesthetist, and sometimes we are subjected to sickle cell patients scheduled for surgery. Now, in our area, we do what we call multimodal pain management. This includes the opioids, the NSAIDs, and the acetaminophen. Now, for this specific patient who is a sickle cell patient, just like my previous colleague was said, management is about thinning of this blood. Now, I'm worried about the bleeding tendencies in this patient scheduled for the major surgeries in as far as the NSAID drugs to this patient, and also including the preoperative transfusion in case you have a patient with an HB of less than 10. So can you clarify that? Because this is a patient sometimes we might have emergency surgeries scheduled to this patient, and you have to do it regardless.
I think before any operation, there is a history taking. So if you are in NSAIDs, even those patients who have like preeclampsia, when you are on aspirin, you're told to stop 1 month before surgery. So it will apply the same even to a sickler. They have to stop any NSAIDs before the surgery. There is preoperative consent form that people sign. There is a preoperative explanation. You take proper history before including anyone in that any surgery. I think I'm done.
Thank you, thank you. A round of applause, please, to her. Thank you, a heavy one, a heavy one. A heavy one until she reaches her seat. That's nice, she has done very well. I think we are not taking questions now. Maybe what we can do is additional comments, because she's sitting down. Additional comments will do.
So maybe I want to just help Gladys in that. I think sometimes as clinicians we have fear of using drugs because we do not want to understand the interactions of the drugs. But your opioids are your go-go for these people. The pain is just too excruciating. And their life is not as sweet when they're in pain. And you just need to make it better for them. So don't fear giving those morphines. They just work 15 minutes and this person is up and about. So your pain scale on this patient and bringing them to a better stand is what you should really work on to achieve. So let's not fear. We don't need to stick on the NSAIDs for these patients. So kindly, let's upgrade. Let's just learn more. Let's get to know how to better their lives. They're living very successful lives because there are things you learn even in terms of sometimes when we delay with the pains, we miss out on strokes. And the strokes are even diagnosed as early as 3 years, 4 years, and you'll have a child who has stroke. And let's also look at transitional programs because also if you realize, Kenyan policy, we have under 5 treatment that is free of charge. If I happen to be in a study, I will be free of financing in terms of drug. But then again, we lose a lot of these people because there are no transitional programs in our specified facilities. So by the age of 13, 14, 15, they are lost to follow-up. There is no treatment because they have to buy the drugs. So kindly, the policy with sickle cell has to change like yesterday. Thank you.
Nice one, nice one, nice one. As we move to the next presentation now, let us take the final comment. Thank you.
Good afternoon. I'm McPherson from Malawi. As it's been highlighted by one of the comments that probably the best way to manage these sickle cell patients is to, it has been pointed out by one of the commenters that the best way to avoid the cost of treating sickle cell disease patients is to prevent the occurrence of the sickle cell disease. So one way is to enhance screening among our population. So in case they're getting married, they know their status, and then they make the informed choice to have kids or not. Now, one of the comments was about the cost-benefit analysis between upscaling sickle cell disease medications and formulating a policy that prevents marriages of people who can produce children with sickle cell disease. Now, of course, this is a difficult discussion to have because it raises the same concept of eugenics that the Nazis in the early 19th century had to go through. You are essentially deciding what populations you need to have in your areas. Now, if we can bring that into sickle cell disease, it raises that question that where is the line? Where do we draw the line that this is the desirable manifestation of eugenics and this is not? Now, I think it's difficult in our context to maybe start thinking of that now, but it's a discussion that we should at some point have, because these other instances are preventable simply because we're not able to make those tough decisions. But then we also have to consider that people may take advantage of that, and yeah.
Thank you. A round of applause to him, kindly. I think in the future, we are headed to a situation whereby life will be not as natural as pregnancy. You know, pregnancy is natural in the way that you do it once and it's for all. The way, as in, you will not go give pregnancy for the head, then come next week, give the left leg and give the right leg. You do once and it's done. But the way things are going from medical perspective, opinions and everything, policies are to be developed. She brought about the issue of an emotional issue whereby a patient complaining of having been born with the negligence of the parents. The patient took it like it's negligence of the parents. Now, very soon, for we in Africa, we understand that so long as you've spotted a flower in the garden, it is so natural. You won't avoid it. But wherever we are headed to, you will be asking for, please, can I get your sickle cell certificate to know if we are likely to have sickle cell patients. Then you find the flower now with us instead of you having the flower. So it's getting unfortunate for we African men, and I don't know. However much you give policy advice, be considering the African men. Thank you. It was on a lighter note, I understand. The man will also ask for the certificate.
Okay. So it looks like there's going to be a lot of certification before marriage happens, isn't it? Yes. Those who are already married, I think they are free. Those of you coming, you need all the certificates you can get. Yes. Sorry about that. We have some important guests who have joined us, so I need to introduce them so that we know who they are and how to address them. So we have Honorable Edward Zero, the Chair Health Committee, Kilifi County Assembly. Kindly, let's see you. Let's see you. Fantastic. We have Honorable Mwambire Mohammed, member of the Health Committee, Kilifi County Assembly. Honorable, great. We have Honorable Mary Anzazi Maneno. She's the Vice Chair, Health Committee, Kilifi County Assembly. Let's see you, Honorable. Great. We have Habel Sulubu Mbaru, Health Committee Clerk, Kilifi County Assembly. Let's see Habel. So these are our dignitaries who have joined us today, all the way from Kilifi County, Kenya. Fantastic. We move on to our next abstract presentation, and this is by our very own Margaret Waina. Margaret Maina, yes. She is the Secretary General for IAPA. Fantastic. Please put your hands together for her. Her president presented not long ago, and she's following up with her presentation. So,
good afternoon. My name is Margaret Wamboi Maina. By profession, I am a family health clinical officer. I work in Kijabe Hospital, and also I'm a tutor and a head of program for clinical medicine students. So I am privileged to be here in front of you just to showcase a key role the family health clinicians do in Kenya, and also what we can copy from that. So introducing, just before the, okay, so just introducing family health clinical officers as key professional for development of UHC, universal healthcare in Kenya. So the vision of Kenya was using primary healthcare as a means to achieve universal healthcare. And from this, the problem we had is we have only 200 family medicine consultants who are to take care of more than 54 million patients in this country. So clinical officer, how it came about, and you know the history of us as clinical officers, we as middle-level healthcare workers already provided much of the primary care across Kenya, but without specialized training. So we know the basic clinical medicine, we have been trained. But now, as a specialty, that's why we came about having a higher diploma in family health clinical officers. So for this, it was launched in KMTC, but it was coming from a point whereby as an institution, we had a lot of family medicine residents who are from Kabarak. And from that, a lot of evidence we saw, and a curriculum was formed from there. And this is why we had participated in just formulating the curriculum, which was launched in KMTC in 2018. And with this, why family health? The reason is just to fill the gap. Filling the gap for the future, just taking care of this at a grassroots level, we as clinical health, clinical officers. In Kijabe, it was started in 2021, first cohort, and experience delivering innovative and strategic higher diplomas. And in this, since inception, we have us underway having cohorts every 18 months. And because we know we have new regulations that whereby high diplomas are supposed to be trained in 24 months with KNQA. Previously, it was 18 months. Family health clinical officers, graduates, they're the ones who run family medicine clinics. And this is where I appreciate one of my colleagues from Kenya was talking about the NCDs. We are the ones who take care of patients who have hypertension, diabetes, NCDs. So we are the ones who run the clinic, and we appreciate the hospital for giving us a platform whereby instead of queuing, we just have the chronic care clinic where the FSCO graduates are the ones who are running. And then we also have satellites where from the main hospital, we have other, they're able to, as a specialty, they're able to run the clinics. So they offer patient-centered care, evidence-based care, and also holistic care. heavily, and also they're involved in teaching. So the trainees are from diverse areas in the country, especially KMTC training in Kisumu, Nakuru, and Nairobi campuses. And part of this, I'm so proud of them because I participated also teaching part of these cohorts in KMTC. And there's much, because there's that question of what is the difference you bring on board? And still the same question when the physician, the outpatient, they're asking, what is different between a GP and someone who has trained? So one of the vision as family health CEOs, as key thing is just playing a key role in multidisciplinary teams within the primary care networks. So we're able to find on the grassroots, we're able to identify the critical patients, we're able to refer on time, we're able to advise carefully, and also we're able to meet to avoid complication and doing monitoring and follow-up. That's the key thing. Across the country, as a key member of primary healthcare, one of the things is to take care of holistic care, both spiritually, socially, mentally, in a holistic picture, accessibility and quality and affordable healthcare, showing compassion, having patient-centered care, working with integrity, having team leaders, highly skilled personnel, and then also treating the whole family. You're taking care of the family, you're taking care of the community at large. One of the other strategies, when you're training family health clinical officers, it has efficiency in terms of cost-effective way of strengthening UHC. By doing this again, it leads to improve quality of care, particularly for undeserved Kenyans, because sometimes it's tricky for them to go to the hospital when they're having these complications, and by training them and having them to be empowered, what is the main role at the grassroots level. And then the key part they play in helping to achieve the UHC, as you have said. And then we want to prioritize it in Kenya, not only there, we want also to replicate it in other countries. And we published an article in the African Journal, which you can read more. I wanted him to display. It was published in July this year, and just giving us a bigger picture of how the clinical officer who has been specializing in family health, what the big part they play in terms of evidence care, quality outcome, and even they have been participating in quality improvement projects and intervention, because more of the researches we have done, more of scientific, but now coming to fix, it's more like actionable research. You're seeing the gap, what are the interventions you can to do, and then out of that, you're able to meet the needs of the patient. That's part of it, but I would love him to show one of the article that you can read more about that. It's coming up. Okay. As he displays it, the outcome, why we need to think about training the family health clinical officers. Apart from just evidence-based, cost-effective, and one of the strategies, it helps in primary healthcare networks, just networking. We have specialty, where we have the pediatricians, we have the obstetrics, we have mental health, we have oncology, we have palliative. But when we are working as a team, we're able to find and identify key things the patients are having, and then you have to refer them at an early state. And again, out of training them, it's a burden the way the presenter who had come in the morning talked about the NCDs. One of the good things which has happened for us as a facility were in our diabetic clinic. We were able to triage patients who are coming with surgical conditions, and yet it is coming out of the complication of poor control of glycemic. They're having diabetic foot. So we're able to have a specialized care whereby you're teaching them foot care. You're having to ensure they're able to know in terms of their diet, the nutrition is on board, in terms of their medications, what are the things they need to remove. If it is their GFR is high, changing the molecules from metformin and doing other things. just to control their glycemic. So this is the article from the African Journal, Primary Healthcare and Family Medicine. So you can read about this and just find how the outcome has come. Thank you.
Thank you. I think more of it is an input. Thank you. You can start.
Thank you. Thank you. My name is Edward Zero. I'm a clinical officer by profession, and that was the chairperson, Health Committee, Kilifi County Assembly. Okay, I don't know whether it will be a question, but I just wanted to know the roles that you are playing as a family health clinical officer. Are you playing the roles of those of a family physician?
So that's a good question. And it's not the first time as I had started, because where do we come in? What's the difference? But this is whereby out of training a family health clinical officer, it's a specialty one, and the real need why they are trained is, one, to work at the grassroots, because our picture here is the primary healthcare. So identifying the nitty-gritty things which most of the time they are missed at the outpatient. And the other thing is, out of evidence-based care, we're able to reach out and fix more like what do I want to say? Like, one, the diabetic clinic. I will use an example like what is happening in our facility. We are the ones who run the family medicine clinic. So these are patients who have been having special needs in terms of diabetes, hypertension. They are the ones who some have TB, have HIV, have chronic illnesses. That is the point. So we have more focused in looking into these patients to avoid the complications which are coming up with the poor control of these diseases. That's the main thing. Yeah.
Thank you. Thank you for that wonderful presentation. From Kenya, you will agree with me that even before you presented, you just told us that 200 family physicians, and these are the consultants, in a population of about 50 million. That's very few. Now, looking at the uptake, even at the consultant level, we realize that the uptake of general practitioners for the clinical officers in Kenya, going further, studying the higher national diploma for the family health is low. You went ahead and told us that you are even among the lecturers teaching them. What could be the reason? Because in my view, I've had people are not going for this course because they'll still come back to the outpatient. And for those who are from Kenya can agree with me, due to the shortage of staffing, sometimes these specialized clinical officers are forced to go to the outpatient and see general population, yet they have specialized. And maybe this could be the reason as to why there is this low uptake of these clinical officers to pursue this kind of specialty. Thank you.
Okay. Thank you for the question.
First of all, before you answer, is there a low uptake of clinical officers into this specialty? You can start from there.
Sure. I think that's true. And I was trained in the first class. We only had 7 students. And the reason why we have low uptake is because, one, the awareness. Who are you in the marketplace? That's the same challenge even the physician, family physician themselves find a problem. Where are they fitting in the marketplace? And I will use an example because we are borrowing this from them, whereby most of them, when they qualify, there are 2 instances where they are. One, either they are consultant at the outpatient, where we at the clinical officers consult them. And 2, they are the ones who run the MOPCs. So the special clinics, they're the ones who run that. So the awareness to know the difference, who is a family health clinical officer, is what makes someone not to be interested, which is very demarcated if someone is a pediatrician, if someone is an obstetrician, someone is dealing in oncology, and also mental health. So when you're able to sensitize and create better awareness who we are in the marketplace, I think that will be a better position for us to have a scoop and a niche in the marketplace. So I agree totally. And it's still a conversation because the last time I had, this year there was a conference called Wonka. And it was a conference by all the family physicians globally, just to explain the challenges also they go through. So I realized it's not only us, the family health, who have a problem, but they also have a problem to where is their identity bit. But now, where do we start to create this awareness? By one, creating an opportunity that we have a different place. In outpatient, we have those specialized places that we can be able to be given to show the difference. If you have chronic illnesses in the facility, we're able to allow the family health clinical officers to be able to take part in that. And then they're working together. So we don't fight, but we have embraced that umbrella of working together. Because by doing that, we are helping to know what is the difference between this clinical officer who has specialized in this and what is the difference from just a diploma person who just came from school. So that's where we start, sensitizing and creating awareness and then giving us a place where we are able to know we run this show at the grassroots. That's the point.
Okay, let me stand. I like standing when Now, I want to make a comment, not really a question. Now, when we talk about clinical officers in Kenya, we look at our population. Currently, we are at 54 million Kenyans. And then we have doctors at 11,000, just about 12,000 medical officers or doctors. So this gives a medical professional ratio to the population at 1 to 5,000, far away from what is recommended by the WHO. Now we have about 28,000 clinical officers who come in to fill that gap and bring the ratio down to 1 to 2,000. So the clinical officers come in not to fight, but to fill the gap. Number two, we are told, we've been discussing from the beginning, that when we came in, we came to fill the gap, and it's especially in the underserved areas, that is in the rural. And we also have urban rural settlements where we also work. So when we go there as just general practitioners, these populations also have special needs. They need specialized care. And that is why we have specialized clinical officers coming in. What do they come to do? Bringing the services closer to the people. Now we look at the doctors have got the specialized doctors have their clinics, which are far out of reach economically for these populations. What do the specialized clinical officers come to do? They come to bring easily accessible and affordable service to the community. It's not about the fight, but it is about the gap that we are filling as clinical officers. And as we talk right now, the specialized clinics in the primary healthcare facilities are run by clinical officers because we cannot get the doctors in these areas. It is the clinical officers, and I can attest to you that these clinics are very vibrant. Look at the HIV/TB clinic programs. They are actually in the grassroots where a majority of these patients are run by clinical officers. When you look at the specialized, the family health that my colleague is talking about, come to the primary public health facilities. It is the clinical officers who are running these facilities, not to fight, but to make sure that that patient who cannot afford to reach the doctor also can get quality health care. Thank you.
Thank you very much.
Okay, we have a last comment or rather question.
So good afternoon. I am Alice Jenga from Kenya. I want to comment about the family health clinicians, especially in our facilities. They are posted in rural facilities, whereby we know when you're dealing with an NCD patient, you must do the baseline investigations, which you need to do at the start of those reviews. The major problem that we have, and even a gap, and I will post this even to our political leaders who are here. In a facility like a level 2, a patient cannot afford an RB. RBS. So you as a family health clinician, where are you left with this patient? And they cannot afford an RBS. You go ahead, you want to know how their kidneys are. You cannot do a UEC. You cannot do a HbA1c. So, in a way, even if these family health clinicians have trained, those patients are referred to a higher level facility whereby maybe they can be able to do those investigations. So at times, they are seen like not working, because if your work is to refill metformin, refill, and even maybe if a patient was in a higher facility, has been removed from a drug like Nogluk, they were given a DPP-4 or any other beta molecule, they are taken back to Nogluk when they come to a level 2. Because that is what that family health clinician can prescribe and give to that patient. So there is there's a gap, and there is something that we are missing. Yes, we have family health clinicians, but are they improving the quality of care for our patients? But it is not because they do not have the information and knowledge and the training, but they are constrained. So I think something needs to be done. I don't know where it cuts across all other nations, but that is for Kenya. The other thing for the clinic, like where I work, we run a diabetic clinic Monday to Friday. Monday to Friday. And we book 15 patients per day so that you can offer quality care. And our physician is very optimistic. Even when any other person comes to that clinic, they are like, do not alter the way that clinic runs. For us, we have seen a reduction of admissions of these chronic patients to our ward. So I would urge even the clinicians who are here. Personally, I am the in charge. So what I do, I can place someone in that DM clinic. But they'll be like, no. So when we go back as clinicians, let us urge our fellow clinicians, because there are people who feel like this NCD world is too complicated, and it is not. It's just encouraging them and showing them that they can be able to manage those patients and even improve the quality of care. Because we all know MOPC clinic is once in a week for majority of the hospitals across Kenya. So if you're there and you're able to monitor that patient, work with them, it is, you are going to improve the quality of care for these patients, and even you as a person, you feel satisfied that you prevented someone from getting to dialysis by just doing a UEC and getting their GFR. Thank you.
Thank you for that comment. I totally agree. Yeah, the challenges we face. And that's why when we are even training the same, we are also trained how to work in a low resource center. That you can even use a simple dipstick just to see what is happening to someone's kidneys. And I pray that the government can also help. I know sometimes the dispensary are neglected, all those grassroots. But one of the testimony from one of the pioneers for KMTC, they used to go to their houses where the patients are the ones who come to the hospital. But us, when we are well empowered and how we have tools, we're able to reach even to the patients where they are at home and able to track whatever the problems they're having and using the least things we are having. So I agree there are challenges, but I pray that apart from just seeing the bigger picture they are having inability, you have a few minutes of talking to the patient, just understanding what their struggles, psychosocial issues, help them to be able to understand that this person really has a need, and then we see how to chip in. So thank you for your comment.
Thank you very much. Thank you very much. No. Don't clap for her. Don't clap for her. We are going to do it in an organized way. For all the men in the house, if you feel Margaret is beautiful, be upstanding. All men in the house, if you feel Margaret is beautiful, be upstanding. Please. Yes. You mean we have less men in the house? Any man seated, not upstanding. Oh, please be upstanding, man. If you feel Margaret is beautiful. Then I want us to have a coordinated clap. A coordinated clap for her. This is how I'm going to coordinate the clap for her. we have to appreciate her. Sawa sawa. You say sawa. Sawa sawa. Nice one. So you have to open your arms wide open. If Margaret is going to look at the crowd, and if she's going to spot somebody who has opened it very nicely, she's going to give you a hug. Now, wide open. Wide open, wide open. Okay. Margaret is going to see how flowery you are. How flowery you are. Now flower them. Flower it. Flower your hug. Now, Margaret, you can see them? Thank you. Keep on flowering, keep on flowering. Now, Margaret is going to choose on how loud your clap is going to be. On how loud your clap is going to be. Now, you will drop it once. The moment I say you drop it, okay? Flower it. Drop. No. Again, once again. Let them flower it. Drop. You've just had it. Now, before you go, let the ladies come up. Ladies, be upstanding. I want to show men how to appreciate with a clap. That clap is not what Margaret. Ladies, show us how you'd wish to be appreciated via clap. You have to clap it the loudest. Be upstanding, all ladies. If you feel you are a lady, be upstanding. Be upstanding. Now let us have the flower for Margaret. You know, ladies are always biased. They always support their very own so much. Let us see it. Drop. Nice one. Thank you very much, Margaret. Thank you very much.
Wow, that was involving and entertaining. Please. Okay. So Scott got a hug, even though he didn't clap the loudest. He got a hug. It's fine. Because Margaret, I spotted one gentleman on this row. He was clapping till his palms were red, but you gave Scott the hug. It's not fair, but we are okay. Yes. At this point, we are getting to the highlight of the day. We are going to have the legislative forum. And that session is very important because all that we do as clinical officers and physician associates, assistants, it has to be backed by law. It is actually backed by law, enshrined by acts of parliament. Yes. So we don't just wake up and practice. It is backed by law. So these people we are going to have today, they are the lawmakers. They are the ones that formulate these policies. So we are very fortunate to have them here so that whatever we discuss here, we know that they can be enacted into laws, into working policies that would help shape the profession for all of us. So for this session, it is going to be moderated by the big boss himself, the president of GACOPA. So let's put our hands together and welcome President for GACOPA, Austin. Oh, because he's not going to give anyone a hug, you are not clapping. Yes.
And the session I'll be assisted by the Honorable George Gibore, who is the General Secretary of the Kenya Union of Clinical Officers. So I'll just do the introduction, the opening remarks, and then from there now, George Gibore will continue with the moderation. So this Legislative Health Assembly Forum, we decided to put it in our program, and we decided to have it because GACOPA alone is not just an association per se. We partner with different institutions, different organizations. You can remember our journey as GACOPA when we started in 2018. We've visited several national assemblies or parliament. We started with the state, we started with the Zanzibar Assembly, where we met the Speaker of Parliament of Zanzibar. You remember Zanzibar is a semi-autonomous country, but it's part of the United Republic of Tanzania. Though almost 99% of Zanzibar, they do their things their own way. They have the president, they have the vice president. The only thing they share with Tanganyika, where they formed the United Republic of Tanzania, is the security, the army, and all those things. But because even educational health belongs to Zanzibar, Tanganyika also has their own. So last time when we were in Malaysia, we invited some members of parliament. The reason why we are inviting members of parliament is because you realize the gap that we have. Look at what is happening in Zimbabwe. They need legislation. Look at what happened in Burundi. If GACOPA did not go to Burundi, they will not be having an allied health professions council. Just because we went there and engaged the Parliament of Burundi and the Ministry of Health, now they're having the allied health professions council, and the Burundians paramedics, how they are being called, are now referred to as clinical officers. So it is in French, it is called associate clinician, still the same as clinical officers. We are trying to, in the coming discussion, that's tomorrow, when we'll be making major changes, making major announcements, we will be having the first GACOPA African Leadership Forum for clinical practitioners. And it will take place in a country that will be mentioned tomorrow. And I know very many people will want to travel to that country. So today, we're having this Legislative Health Assembly Forum. It is part of the schedule, and I'll be very, very fast. It was to be co-chaired by the Right Honorable Gezi Sisi, but he had an engagement with the President of Zimbabwe. So she sent her apologies together with the two members of parliament. But here we are today. We are with the co-chair. That is the Honorable Dr. Robert Pukose, MP, Member of Parliament for Endebess, and Chair of the Health Committee of the National Assembly of the Republic of Kenya. Welcome, co-chair. As it comes, we also have other members, honorable members, who will join the co-chair. I think the co-chair will sit somewhere there. You know, in Kenya, the chair of committees are the most powerful people. They summon everybody except the president and the deputy. Yeah, they summon everybody in that Republic of Kenya except the president and the deputy. And their recommendation is really binding and very, very powerful. You remember even last time the president named his cabinet and one person failed. Where did that person fail? He failed at the committee. So that is a very important person. So we have the Honorable Edward Zero from Kenya. Honorable Edward Zero is the chair of the Health Committee, Kilifi County Assembly, and a clinical officer per standard. Elected by a majority of votes in his ward. I can remember he used to share with me his program, how he planned to win the election. And I told him, hii umeshinda. Hii imeenda. So we were to have the Honorable Dr. Fred Mavisi, but apparently he hasn't arrived. We have the Honorable Boniface Mabuka, Member of County Assembly, Kakamega County. He is also the Vice Chair of the Health Committee of that County Assembly. So, Honorable Edward Zero from Kilifi County Assembly Sorry. I didn't see him, but he's already there. The Honorable Dr. Fred Mavisi, who is, I know he's having a serious presentation to make after this session, but welcome, Dr. Mavisi. He's been very passionate about our cadre, almost attending all our conferences. We invite you to our next conference, where we will name that tomorrow, so we will still have you tomorrow, so that you witness the naming ceremony. So one chair should just be added there, or two. Honorable members are so many. So the Honorable Mary, Kilifi County Assembly, at least we are now trying to gender, mambo ya gender. By the way, Kiswahili is an African Union language, so you can just mix it. Honorable Mary, karibu. And then Honorable Mohammed, also a member of the County Assembly of Kilifi. Kilifi is well represented here, and I think GACOPA will issue a citation of honor to Kilifi County Assembly at the end of the session tomorrow. And it will be delivered by the chair of the Health Committee together with the chair of the Kilifi County for Clinical Officers. So you will invite me there so that we witness that ceremony. So my moderator for today, because me, I was just doing the introduction, is George Kibore. He's going to be next, in 2027, he'll be the Member of Parliament for Kuria West. And as GACOPA, we want to try as much as possible so that all our members go into Parliament. As others become professors and venture into education, we are also trying. I'll also be vying for the Super North parliamentary seat. So, karibu.
Thank you very much, Mr. President, for that introductory remark. Once again, let me introduce myself. My name is George Gibore. I am a clinical officer. I practice in Kenya, and also I lead the Union of Kenya Clinical Officers as a General Secretary and a co-founder. And to that respective, we normally cooperate very much with the respective honorable members who are here to come up with a legislative framework that support the practice and enhance service delivery. And that is one of the key issues that we want to deliberate on. And I will allow them to introduce themselves after having been introduced, but we know we might not have introduced them the way they will wish to be. We will start from the far end so that it come to Dr. Bukose, who have been here with us since we started, and I know that he arrived here even before us, majority of us, and every morning I come here, I find him, he's here before us. So he has been quite passionate about this. So you'll take a moment of introducing yourself and probably give a statement of what you understand about the topic that we are going to highlight about on the legislative framework on health.
Okay, good afternoon. My name's Armambire Mohamed Kadengi, a committee member of the Health Committee in the County Assembly of Kilifi, a member representing a ward in Kilifi called Bamba Ward. And I'm happy to be here, that we know very well, as stated by earlier speakers, that most of the health issues need proper legislative. We have been taking that step in our county, and some of our clinicians will attest that we have taken most of the important legislative to the county assembly, and we are making a very close follow-up to ensure that most of these legislative policies are implemented. When I came in, I found a very touching topic of people who are really suffering in the rural areas. And it has really challenged me. I was whispering my chair there that we need to make sure that some of these measures needs to be taken as down to the dispensaries. And the family clinicians, the topic was very touching to us, because you'll find that people are traveling from very remote areas, going to where we have the referral hospitals, because they cannot find these medicines in the dispensaries, and they need to move from very long distances to go and get the medicines. So I feel it's an area that we need to look into it, so that the communities, the people from the less privileged people from the rural areas can be at least attended at the lowest level unit of a medical center. Thank you.
Thank you very much. That's in order, because then it conforms to our topic, legislative framework as a catalyst to universal health coverage. Next speaker.
Thank you. My name is Mary Anzazi Maneno, the Vice Chair, Health Committee, Kilifi County. We are here also to learn more about the health system through the clinical officers. As in Kilifi County, we have passed so many policies which, when implemented by the executive, will help and assist the clinical officers to work in a better environment. So, for the honorable members from other counties and countries, we need to pass policies which will assist our clinical officers. Thank you.
So before we introduce, before Honorable Fred introduces himself, I have the pleasure to introduce the Honorable Palelo Mutaosane, Member of Parliament for Tamaga constituency and Chair of the Health Committee, Parliament of Botswana.
Thank you very much, and welcome, Honorable Member Palelo. We are introducing the panelists, and we are happy that you came at the right time, understanding that you have a very busy schedule, also knowing very well that there is election around the corner. You're most welcome. You have an electorate here, they will be listening to you. Next.
Thank you so much. I am Dr. Fred Mavisi. I am a member representing a ward in Kenya. I am a consultant pharmacologist and a specialist in infectious diseases. And I'm glad to be here to be part of GACOPA and the clinical officers fraternity. I would say the legislative framework in health is one of the core building blocks in a healthy system, healthcare system, that comprises of one of the six, that is leadership and governance. So I'm here as part of the panelists to explore, probably share what I know about it, and be able to learn from my fellow panelists on what we can do as legislators to improve healthcare systems, as well as universal healthcare attainment as part of the SDG goals in this global world. Thank you.
Thank you, Honorable Fred. Next speaker.
Good afternoon, everyone. My name is Boniface Mabuka. I'm a clinician by profession, and I'm also representing a ward in Kenya, in Kakamega County, in Matungu sub-county. I'm glad to be here. I've been here since the first day. I've been working alongside clinical officers since the beginning, I think, of the conferences. And I'm passionate about it, and I'm willing, with God's mercies and help, to go ahead and also participate in what will benefit clinical officers. I'm a champion for gender-based violence. Among the policies that I've managed to make at where I'm working. And during the participation or during the discussion that we'll have, there's something which was discussed here before, yesterday and today. But that really affects Kenyans about the under 5 treatment. It is not clear, but I'm glad Dr. Bukose is here, because apparently some of the counties right now, the under 5s are paying for treatment. I don't know whether you are aware, but it's silently being done. It has not come out very clearly. Since we have members of parliament present with us, they will help us understand why that was done. If it was done at national level, why was it not communicated directly to all the 47 counties? Thank you so much.
Thank you. Next panelist.
Thank you. Good afternoon. My name is Edward Zero. I'm the chairperson, Health Committee, Kilifi County Assembly, and I also am a clinical officer. I'm representing a ward called Mwanamwenga Ward in Kilifi County. Okay, I'm glad to be here to walk through this journey. This is my second GACOPA conference to attend. The other thing was in Malaysia. And I'm glad to be here and all to applaud the organizer of this event. Actually, I think the president has forgotten, but the reason as to why some of the English officers decided to vie for the political seats, it is because of the stigma and recognition by most of the countries. And that the path that we're trying to walk right now, so that clinical officers can be recognized in the whole world, which will be a great achievement to this movement. So I'm here to be part of the policy formulation champion. We make sure that we have some legislation that will favor the clinical officers so that they can be recognized worldwide. Thank you.
Thank you very much. As Dr. Bukosa introduced himself, I will be very specific in terms of having knowledge that Kenya has launched UHC several times. And we wonder whether we have something to put on the table in terms of what we have achieved. As you do that, your introduction remark will be answering or rather responding to what are the legislative framework that we have mostly that we have been most effective in Kenya for promoting UHC, and how can this be adopted and be replicated in other countries?
Thank you, MC, and good afternoon, everyone. My name's Dr. Robert Bukose, Member of Parliament, Endebess. Endebess is in Trans Nzoia County. Endebess was the last base for the Second World War British Army. It was end of the base, so our people called it Endebess, in short. I am the chair of the Health Committee in the Kenyan Parliament. And by profession, I'm a consultant general surgeon. I still practice. I do operations in mostly in Endebess, sub-county hospital. I mentor the young doctors who are there, and also being a chair, I've also managed to support the infrastructure development within that area. The hospital, we are putting up a new hospital there, which will cost around 300 million. And then I've supported one of the dispensaries to become a health center. Initially, when I was elected, I built, before the devolution came in, I built about 7 dispensaries within my constituency to support the healthcare services there. Being here to me is an eye-opener because I was really interested to understand the clinical officer's position within the global framework, and also look at it, how are you placed within the county? And as Engineer Ochola presented in the morning, that's why I had an interest in terms of looking at the career progression. How are you progressing within the career? Because I think that is very important to look at it, how the clinical officers as a profession progresses within the system. And to me, the position of a clinical officer, as much as others are saying you are a physician assistant, you have a distinct position within the healthcare framework to which your work is not subordinate to anybody. You have a position which you are able to see patients. You'll find that beginning from level 3 of the health facilities, that's where you start seeing clinical officers, and possibly up to level 5. When you now come to level 6, maybe anesthetists and subspecialties of clinical officers, now you are able to look at that. In the Kenyan health demographic, you'll find that in the national referral facilities, you constitute about, I think, 4%. Manasseh, I think 4%. So you transcend across all the sectors in the healthcare provision. And I think Ochola and the members of the Public Service Board, we need to, I thought it should be even better if we can cascade it even further, that we have clinical officers up to even at the dispensary level, because we can be able, what they need is an infrastructure support so that they can be able to offer services and be able to manage our healthcare system. When it comes to the legislative framework that we have in terms of supporting universal healthcare, we have had several trials, several trials which have been done to see how to operationalize it. I think we had one done in Kisumu, Machakos, Nyeri, where they did some pilot studies on how to roll out the UHC, but it did not pick up, and this has been done severally. Under the new government, the Kenya Kwanza government of President Ruto, we came up with the several acts now which are in place. The primary health care, the FIF, digital health, and the social health insurance. Apparently, they have run into some headwind in terms of litigation where the court has declared some sections of it being unconstitutional. But we've also managed to get stay orders, and therefore, with those stay orders, it means the program will still have to run on, and those sections that are unconstitutional can be corrected through legislative amendments. And when you look at these laws that are in place, especially the Facility Improvement Fund, that is where you come in, and my colleagues here from the county assemblies, that is where you are able to come into, because when facilities are generating money, that money should be pumped back into that facility to improve on either equipment or even supplies, commodities, which can be able to assist the various clinicians to be able to see patients and manage them well. But apparently, I think it is only Makueni that has operationalized it, but many other counties have not been able to operationalize. But we are hoping that now that this has been passed as a national law, then each county can now be able to operationalize it to make sure that whatever the facility generates, that is money that is protected. That money should be able to go back to that facility, and whatever each department generated should even go to that department to provide the services. So Facility Improvement Fund is one of those laws that is in place, and I hope that counties can take it up. The other laws, the digital health law, in the current budget, we've given them 100 million to operationalize it so that we can now be able to link up the whole country into a digital health system that can be able to assist you even when you want to you want to consult maybe through telemedicine and other frameworks that can be put in place. Then you can be able to consult either within the county or either horizontally or vertically. The other one is the primary health care, which will be able to take care of the emergency, chronic, and critical illnesses. And this is a fund that currently, as we speak, we've allocated close to, I think, primary health care fund has 4 billion, while the emergency, chronic, and critical illness fund has 2 billion to operationalize it. But as per last week, we've asked the Social Health Authority to be able to come up with a clear budget. And I think as soon as they are ready to make a presentation, once I get back to Nairobi, then we will ask them to appear before the committee, the cabinet secretary together with the team, so that they can give Kenyans before the rollout. And the rollout is expected to be on 1st of October. So before that rollout is done, then they must be able to give us very clear what are the benefit packages. And in the presentation by Gladys, I think there was one of the clinical officers, lady who asked, I think you're from Kilifi? Yes. She asked whether hydroxyurea is captured in that. It is captured. Even aphoresis is also captured. And we will want them to also present that package so that we, as a committee, we can be able to look at it and agree with them so that when they roll out, then Kenyans do not miss into the critical services that they require.
Thank you very much. Thank you very much, Daktari. Makofi kwa Daktari. I know I use the word makofi, and some of you come from areas where you don't understand. That's meaning clapping and appreciating that he has given quite an elaborate statement. And to that stage now, we come to our host. As we welcome you, we will start with a question. Paleo. The question will be quite specific. You come from a legislative assembly, that's the National Assembly, where you are able to establish laws. And it is at the interest of any legislature to ensure that the acts that you come with the law, they are fully implemented. We are well informed that you have a law that provides for the existence and the training of clinical officers in the country. But unfortunately, the institution that only trains clinical officer has come up with another name, calling them medical assistants, the doctor assistants, which is not established in any law. Is that the responsibility of your committee to harmonize that? And if so, how long can it take for you to do that? The second is, so far we have close to 230 who have graduated several years down, and some now specializing. But none of them have gotten an opportunity to be employed in the government. We are all also informed that you do not have enough. Is it at your interest, the Committee of Health, to ensure that they can get an opportunity to be employed in their own country? That will be our question. I can allow Mr. President probably to clarify, because you are not here to follow our statement, so that he can also clarify for you to get the real gist of the issue. Thank you.
So, the Honorable Chair, Just a clarification. I know maybe you are not aware of the existence of clinical officers, and you are not privy to the conference that began 2 days ago. We wrote letters, but now that you are here, we are so happy, and I believe that after this legislative forum, our honorable members, we are needed in Parliament right now by the Speaker of Parliament and the Minister for Health. I know is there. So I think this opportunity, more of this discussion, together with the honorable members here, we'll discuss it with the Minister for Health in Parliament, and you will help us do it, and the Assistant Minister for Health. So as we will be moving, I will also be engaging you on who these clinical officers are, why are they training doctor assistants, and the 230 that have not been employed. But in summary, this forum was, we brought this conference to Botswana to help the 230 doctor assistants who are not employed. They are clinical officers. They are not employed by the government because of the uncertainty on who are they, because the law recognizes clinical officers. Yet, I'm sorry to say that, clinical officers from other countries are being employed here, yet there are 230 who needs the employment, and some have even specialized, like Mufenyi Maripe, who is now a dermatologist. I think if you look at the consultant dermatologist in Botswana, there are not even more than 10. But now we have a clinical officer here who are specialized, and those are cases that we'll explain. So in short, maybe the questions that the co-host, the co-moderator has asked you, maybe if you answer, most of them I know you'll be answering when you go together to Parliament, but maybe you can just have something to tell the delegation. These are delegates from more than 20 countries.
Thank you very much. As he answers, we want to appreciate the clinical officer from Botswana. Please, may you be standing so that the honorable member can appreciate that you are here. All of them, those who are training, those who have completed and those who are training. Thank you very much. Some of them might be out. So those are your... Oh, yes. We will be able to introduce him later. Now you can proceed, sir, and introduce yourself.
Thank you, sir. Thank you, Director of Ceremonies, and good afternoon, everybody. It's a pity I've just been made aware of this conference when I was engaged in another activity in my constituency. Unfortunately, when I was asked to come here, I was not even briefed about what the conference is all about. I'm just coming in and, I'm so sorry that I'm not going to be able to say anything to your expectation. But let me just first introduce myself. I'm Palelo Mutaosane from Tamarakumba constituency. Tamara is just a village from, 45 kilometers away from the town. And I'm the chairperson of this health committee, portfolio committee in Parliament. I just got into that position 1.5 years ago. I'm not a health professional. I'm only an admin and finance person. I sit in many committees like Public Accounts Committee and many other committees like Agriculture, Health, and about 7 or 8 committees, since our Parliament is very small. We have a very small number of backbenchers, because here in Botswana, our committees are made out of only the backbench, not the ministers. So, there are many committees and we are very few. That's why I'm sitting in so many committees. But to try and answer the questions that have been asked to me by the Director of Ceremonies, you will pardon me on this, because honestly speaking, especially when you are not a health professional and you are put into this without any briefing from the relevant authorities, it becomes a little bit difficult. Otherwise, I'm going to say something that will make my government look like, they don't know what they are doing. But primarily, I want to tell you that we have been doing quite well in Botswana in terms of our health system. It's just lately that we are seriously struggling with a number of issues like medication, staff, meaning doctors, nurses, and any other profession in the health care system. We are struggling a lot. I just heard that we have trained more people and we can't give them employment. There's a big problem here in Botswana, especially that, we have this DPSM, the employment barrier, I can call it that way, the employment barrier, government employment barrier. They need to have some posts to employ people in those positions. And the Ministry of Health has been struggling with quite a number of positions that they are trying to develop in their system. So we take this to the DPSM to create posts for these people. I know we have been training quite a lot of people or furthering their studies to specialize in particular professions in the health system. And I'm not aware that we have so much that are not employed who have already completed their studies. This is why I seriously needed some briefing before I could give you the exact update of what is happening in our country. I really wouldn't want to say much about that. Only thing that I can say is that our health system is one of the best in the region. Although we are always short of professionals, we train doctors, they stay wherever we are training them, like in UK. We train people in UK to go and specialize. Because of the remuneration that they are getting here, they normally don't come back. Some come back to just take a year or two to, complete the government contract, and then they go back to a UK. Otherwise, if it wasn't for that, you would be having enough. But like you are saying, there is quite a lot of difference in what you are doing in your own countries. Like we have doctors here, we have nurses, we have other professions in the health sector. But here you are calling them the physicians and medical assistants. So I don't want to commit anything before I can be, briefed about what we are doing here. But we are, as a government, trying to improve our legislative systems to align them with the World Health Organization. That is where we are dealing quite a lot with our legislative issues when it comes to the health sector. We have a number of legislations that we have just made in the past 2 parliament sittings. One is like the mental health care. Those are one of the legislations that we just passed through parliament. But I can honestly say our laws are truly aligned with what requirements are there with the World Health Organization. So let me not go further than this because I honestly needed to have looked at a few things before I come here. Thank you, sir.
Very much. Thank you very much, Honorable Lelo, for being honest and for your response. I do not want to pretend to know what these members want really to know. I will allow them so that they can ask. We may have someone to move the mic so that we get direct question from them. As we do that, I will ask every panelist here to ponder around the issue of, these are clinical officers, physician assistant, medical assistants as they may be called, but they will wish to choose where even to work. But we have some hindrance. And this hindrance even exists within our own continent like Africa, which we can be able to eliminate under our existing structures. Like for instance, I come from Kenya. We have what we call the East African region, where they can be able to come up with one framework to enable cross-borders movement. And similarly, we have the African Union that can now make it even easier for any worker to move around and offer services. As you understand, we work in a very key sector where diseases has no borders. And we do not understand why the resources have borders, like the human resource. So even as we know there is campaign to ensure that we have the AU representative, or rather the chair, we want to get to understand what will be your contribution to ensure that we have a framework that anchors such an expectation from the workers here. I will allow members to take question.
Okay, we have the first
by
question.
Show of hands, by a show of hand, we'll give the first three first. So he is already standing.
We have a gentleman here. Another question?
Any other person? You seem to be very comfortable.
No, I think maybe other questions can be generated from this question.
Sir, thank you.
Good day. Thank you for the opportunity. Very emotional to hear my member of parliament. Though I appreciate the honesty that he brought to us, that maybe he wasn't briefed of this day. But I want to comment on one or two things that he just brought. I had almost 6 questions that were directly directed to him specifically. The first one was a disappointment on our members of parliament, not only him, all of them, for not finding time to attend such an important conference. The reason being, this conference was brought to our country deliberately to help us. I'm fully aware that on many occasions, the Kenyan guys came, including my president and his delegates there in GACOPA. They came here to try and help explain what is the difference between BDA, and BDA means doctor's assistants and clinical officers. The difference is basically the same. Standing here 5 years after graduating, 5 years down the line, that was, I graduated a year, just on the year of their elections. Now we are going on another election. I'm unemployed. As competent as I am, I've worked even in the government hospitals. I have references from the specialists from the government hospitals. But 5 years down the line after my graduation, I'm still staying in the farms. But also to give a bit of background, we have battled with the government, specifically with the BHPC, in the courts of law. We have won the case almost 2-3 years ago. The courts have found it fit for us to be licensed. But we are standing here 3 years down the line. We don't have the licenses. Members of this issue of bachelors of doctor's assistants, I'm giving you a brief history because I want to end by saying I'm a bit disappointed by my member of parliament that he says he did not know about doctor's assistants. Maybe he'll give an answer. This issue has been discussed. It was brought in parliament twice, if not thrice. First, this was brought by Honorable Ditapeleko Rapezi, the Member of Parliament for Pikwe West, who currently holds a position of Leader of Opposition. This issue was also brought by my Member of Parliament, Winter Muluti, and Honorable Muswan. All are members of Parliament from Francis Town. So I'm fully aware that this issue was discussed in Parliament. And one of the sessions, Honorable Mutawasan was there, my honorable member. I understand he holds many positions in terms of committees, but he's been in a position of chair of health for almost a year, so he said. It is a bit disappointing. Kenyan legislatures, they came here, how many of them? 1, 2, 3, almost more than 3 that are here. But members of our, 7 of them, but from our country, none. We had Honorable Triple P. Matud, who holds a position of Deputy Speaker. I've met him in person in Francistown. I've talked to him in person about us. But it seems none of our members of parliament cares. I'm happy that you are here, sitting here as the chair of health committee. And I am very happy because I know from here, before the end of next year, we'll be having our licenses. I pray to God that you win your position again. Reason I'm disappointed is Kenya has done so much in terms of clinical officers. They even have specialists. Maripe, the dermatologist, she'll be graduating from Kenya. Oh, Tanzania. Tanzania and Kenya, they're all cousins. So I usually confuse between the two of them. So Kenya has come all the way from Kenya. 7 legislators have come from Kenya to come here and educate us, to come and help us do better. I'm grateful that from here you are going to have a seat with them in Parliament. Please, I repeat, please, let that meeting come out with a resolution that will get our licenses as soon as yesterday. I wanted to ask you, as a member of parliament, now not holding a position, that what have you done to ensure that you, or the efforts you have done as a member of parliament to ensure that us as physicians assistants or doctors assistants get licensed? That is, what contribution have you made in parliament? But you have made it clear that you did not know of us, which is disappointing because I'm so certain from your constituency, we have almost more than 5 graduates who are coming from your constituency, but it seems you do not know of them. It's a bit disappointing. I'm sorry when I take a pause, I'm a bit emotional. I've been sitting home for 5 years, and I've studied my program for 4 years, and I've never failed in any of my modules. So it becomes very emotional to be unemployed, holding a degree, and in a program that is highly needed in our country. So give me the chance to take a bit of a breath and address my member of parliament, whom I love so much. I know he does a lot for us. He really does a lot in parliament. So I was a bit disappointed because it means for me, he didn't do a lot for me for these 5 years that he was given. So I'm a bit disappointed, but my love for him will never change. The challenge that the reason I want to be the first to address you is because I've run back and forth with my president and other guys. So I would, maybe before you get there, you would have had a bit of insight. The challenge that we have is the independence between Ministry of Health and Botswana Health Profession. The problem yet now is not with DPSM. DPSM, their role is to hire us. The challenge that we are having right now is we do not have licenses. I've had 3 hospitals interested in hiring me, private hospitals, but they couldn't hire me because I didn't have my license. It's painful, and I'm not the only person who's going through what I'm going through now. Some of us are brought by very poor families to make us be better, but we are seated home with our own poor mothers. Please, Honorable Mtawasana, I have a lot to say, but I'll stop here. I hope you will do better from today until the day that I'll get my practicing license. Good luck on your elections. We hope to see you again in Parliament because we need you. Thank you.
I think
okay, very much.
moderator, please. I think we can allow the Honorable to respond on that before we take any other question.
That
And Honorable, please, you can allow it to come out as natural as pregnancy.
Yeah.
Please, don't hold on it.
Thank you very much for that clarity. Honorable members, as you'll hear, I think I'm also moved. If I was the one, I will be taking action so that you start from where you have an act of parliament which give you powers. It has given them title. Someone trains them, giving them a different title, confusing the whole situation. So once they come up with a different title from what is on the act of parliament, then the one that is supposed to give them the license says, no, I don't know you. So the Ministry of Health, the training institution, and also the accrediting institution, they are supposed to be brought together under your committee for purpose of having a way forward. I believe this can be done even during this election period. So if you feel there is something that probably he highlighted that you could not understand, he's available. And there are many here. As I made them to stand, it's because I wanted you to understand. We have listened to them, and their stories are quite emotional. So maybe I will allow you to respond so that they can feel addressed.
Thank you, Director of Ceremonies. My brother, I'm so sorry. Maybe it was a slip of a tongue to say, I don't know about this. I don't know about this conference. I should be honest with you. I don't know about this conference. I should have brought my notes, and I would be giving you what we are doing as a health committee. But I'm a little bit disappointed because now it's like I'm going to start putting my committee and my ministry in some kind of a dilemma that one would not expect. But to be honest with you, Member of Parliament, I'm not sitting alone in this committee. I understand when the Deputy Speaker asked me to come here, he told me he opened the session. I was like, what? You opened the session at a health a conference, and the chairperson of the health committee doesn't even know about this conference. That's one thing that really disappointed me. But I thought I was coming here to just listen to what is going on in the conference. I didn't know I'd be confronted with quite a lot of issues like that. But, you know, once a soldier, you carry your gun with you. But my brother, let me promise you one thing. I know what you are talking about. I know you are frustrated. I'm the one frustrated more than you can think. Because a lot of our graduates are in the streets. It is not what any legislator would want to see. And I believe even my government, I might simply say we have actually trained more people than what we can consume as a government. But honestly speaking, training people does not necessarily mean people are going to work for the government. The private sector should come in as well. But what is disappointing about what he said is that, I know we have been fighting in Parliament about these people who were trained at these colleges like DDT. And we were up in arms with government. But why, how can we send people to school and today we can't give them licenses? This is what we have been saying to the government as parliamentarians. This issue, I didn't know about the court case that it has finished. But as a legislator, I'm willing, especially as the chairperson of this health committee, these are the issues that have been confronting our staff with them. Even the minister, he will tell you how much I've been complaining about this and trying to get them to get this case done. It's unfortunate, I don't know how far it is with the cause. I know. But yes, I have disappointed you because you haven't got your license as we speak. But we have been seriously advocating for you about this issue. And I don't know how to put it so that it can please you and your colleagues, but like I'm saying, generally speaking, many professions, we are losing a lot of, especially the health sector. This is the sector that we should not be saying we don't have posts for them, because health is critical. For anybody to be productive in any industry, we need health people, we need a healthy workforce. So I'm a little disappointed with the statements. Sometimes, like when you mention my colleagues who brought this to Parliament, now it's becoming political, whereas it's not supposed to be political in a setup of a conference like this. But you were stating facts. Yes, we have discussed this. We have been forcing government. We have been talking to what is it, BOMRA, or the licensing authority, that they should give you your licenses, because government has spent money sending you to those schools. So it is a bit of a disappointment for all of us. Unfortunately, I couldn't help it, and I'm sorry, my young brother, because whenever you are carried up, you are so hurt. I'm hating too, because like you mentioned, you have some of our graduates, they are coming from poor families, and you educate people to try and get their families out of that poverty. I understand you fully, and I will take it up with my minister today. If you are going there, now I think I have to go and lash my minister very hard, because I don't know how a conference of this magnitude could come here, and I don't know as the chairperson of the committee. It's serious disappointment. But pardon me, let the conference go on. We will take it up, and I wish you could have a word with me outside this conference so that I can understand. All of you, you should come. Let me understand what is going on so that I can help. Thank you.
Thank you very much for that response. I will have to is there anyone who has a burning issue? So far, none. So I can see one, two. There is a lady there. So as they do that, I'll allow Dr. Bukose first to respond on what I had talked about cross-border. What are the enablers? What is it that we need to do? Yes, in terms of the legislative framework, what are the limitations and how can we
thank you. First, I want to really appreciate the young doctor there, the young clinician, for being very magnanimous in his expression of his issue. I think that is the way to address your issues. I think that is a very good way of putting it forward, because it has a lot of respect and is able to send his point home. I think, to me, that is very commendable. And I think we can also, especially us from Kenya, we can emulate that kind of way of approach in terms of our issues, because saa ingine tunafanya vyetu ile tofauti. And I hope that my colleague here will be able to take it up as he has promised with the cabinet, with the minister, and also with the licensing board, so that this issue can be addressed. Because if you have 240 young people who have graduated and they are waiting to be licensed so that they can have opportunities for the last 4 or 5 years, then it is very frustrating. In terms of our cross-border, I think to me the take home here is that after this conference, you know, we'll need to do some legislative amendments. And that will be able to, that will be, you want change of the name from clinical officers to clinical practitioners. Yeah? So we'll have to do some legislative amendment. But one, you need first to liaise with the international educators, Scott and the team, so that ILO and even the WHO can be able to recognize, so that you are recognized worldwide. That's in the WHO and also in the ILO, so that we do not have a conflict. We call you clinical practitioners, and then in another country they are called physician assistants. In other country they are called clinical officers. So you'll still continue with the problem which our colleagues in Botswana have faced. So we need first to be able to do a legislative amendment so that, and it should be recognized by WHO and also the ILO. That is where we need to do.
Thank you.
Secondly, we need accreditation in terms of your associations, so that if you are trained in Kenya or you are trained in Tanzania, or trained in Botswana, we can practice within our regions. And then we can also have that accreditation within other international countries, within all the 195 countries, so that you can be able to go and maybe if they require that you sit for exams, or you directly transit into working within those areas. I think those are the things that we can look at it in cross-border. And then the level. We need also to look at what level of healthcare you can be able to work with. I think that is also important, because are you working at the primary healthcare, at the level 1, level 2, level 3, level 4, level 5, and that kind of levels. So I think those are areas that if we have uniformity in terms of those areas, then we can be able to have a uniformity across borders.
Yeah, let's appreciate that. Thank you very much, Honorable Pokose, for that response. Because he has a mic, I will allow him. You have, okay. Thank you. I wanted to allow you to ask yours only, yes. And then I request, because of time, we are being dictated by time. We are also required to take the honorable members to meet the National Assembly together with the host. And then we are also required, we're being called because of the time constraint, so that we can be attended by the hotel before the servicemen can leave. So with that request, for those who had other issues, I know we'll still be having these honorable members around. We can interact with them. Let him. So you have given up. You have submitted. Okay. Thank you very much for that. I will allow the president to finalize, and then now as he continue talking, I will request the honorable members to leave, and as he finalizes and giving directive to the congregants.
So, as we go for lunch, Honorable Mabuka, who is a clinical officer per standard, has something to say. Let's go for lunch. We meet here after lunch for abstract presentations. Some of the delegation will head to Parliament to meet the Minister for Health. We also told the Vice President of the Republic is there. So at the end of this, the doctor assistants will get their licenses and will start practicing. That is why we brought the conference here. That is why we brought the conference here, and it is going to work, and it is working.
Colleague, I have just a concern. My question is one. Why are we struggling to get a name, and yet we have a name? We are clinical officers. Why are we struggling to get another name? Or you don't like that name? But it can be international. What is wrong with a clinical officer? They said they had no problem with it.
Most of your work. Now you will have to pay me.
I'm not getting paid.
Too bright or too dark? Maybe for now it's okay. We'll see as time goes by.
here is Pauline Bichanga from Mombasa, Mulaleo Health Center CDF. So here today I'm going to present to you a project by the a project of child nutrition and child nutrition and its outcome. So before I start, it's good if I can give you a Hello? Hello?